Hello, I'm Josh Hickman. I specialize in hip and knee replacement, minimally invasive hip and knee replacement, as well as hip resurfacing and knee resurfacing. I also take care of second and third time knee and hip replacements that have been referred in by outside facilities that are a bit more complex than your first time knee or hip replacement. We have an incredible staff here at Mountain Orthopedics. We have nurse practitioners, a great administrative assistant and medical assistant. We're here really for you and to answer questions, to make sure your experience with your surgery is as smooth and informative as it can be. We take great pride in providing a high level of service and the highest level of care that is possible. I did a fellowship in joint reconstruction and complicated joint replacement, as well as less invasive joint replacement, and take great pride in focusing on that primarily in my practice. I certainly hope you use this website as a resource for information, and hopefully it'll serve as a springboard for more questions that you may have going forward. I'm going to spend a little time talking about arthritis, both of the hip and knee, and talking about how we do the procedures we do, and really giving you a detailed explanation about what we are going to do and what to expect. My nurse practitioner is going to go over what to expect after surgery. She has a video for that. And hopefully these resources will be helpful in answering questions and also helpful in your recovery. I'd like to talk to you about arthritis of the knee. Typically, a knee is fairly simple. You have ligaments, the medial lateral collateral ligament. You have meniscus. You have the anterior and posterior cruciate ligaments. And then you have the cartilage that coats the end of the bone. This cartilage is typically 5 to 8 millimeters in thickness, and it's made out of cartilage cells. When these cells die, that's arthritis. So this thick surface on the end of the bone gets thinner, and ultimately bone becomes exposed underneath the cartilage surface. We can see the cartilage on an x-ray. This knee to the left, this space between the femur bone and tibia bone is actually the cartilage that coats the bone. These cartilage cells are made mostly of water, so you do not see them on the x-ray. As opposed to the left knee, where all of the cartilage cells have dissolved, they have died, and it leaves the appearance of bone against bone. In addition, osteophytes are formed. This is a severely arthritic knee. This is a mild to moderately arthritic knee on the right side. When you reach this level of arthrosis, there's very little to do to improve the function or outcome of the patient outside of knee replacement or knee resurfacing. The process of this surgery is we digitally size the knee to get the right and correct size of the implant. We then do a spinal anesthetic, a nerve block. These are typically less invasive forms of anesthetic. We do not typically intubate the patient or use a tube. The spinal and nerve block are very good in relieving pain and are very safe for the patient. We then do a small incision. We try to eliminate any damage to muscle. And through that incision, we then shave the end of the bone and cap it. This replicates the lost cartilage surface on the end of the bone. We use this titanium component to cap the tibia bone and insert a polyethylene liner to allow articulation of the knee. We preserve the ligaments, the medial collateral ligament, lateral collateral ligament, and the posterior cruciate ligament. These are all preserved. We occasionally resurface the patella if needed. But in a sense, you can see this is more like a resurfacing of the bone than chopping the knee out. We frequently use robotic techniques to ensure the orientation, the size, the placement of the tibia and femoral component in a position that optimizes ligament balance, range of motion, and stability. Due to a combination of anesthetic techniques, the surgery itself, anesthetic injections we perform during the surgery, medications that we provide, most patients are allowed to go home the same day of surgery. They typically have outpatient physical therapy and have limited restrictions. By 3 weeks, most people are walking normal, they are driving a car, and by 6 weeks are able to do everything they want to do. With that said, this is a difficult surgery. There's swelling, there is discomfort, and sleep can be difficult for the first 6 weeks. There is a wide range of recovery profiles. Some recover quite fast and some are quite slow. But in general, most people are doing well and appreciative of having the surgery within 6 to 8 weeks. Any surgery is a difficult process, and knee replacement and knee resurfacing is a difficult recovery. However, it allows you to get your life back. You're able to backcountry ski, downhill ski, helicopter ski, hunt, fish, hike. Some people run. Some people are able to do many things that they could not do prior to surgery. Overall, patients are highly satisfied with this procedure and are very grateful to have had it done both in pain relief and improvements in function. I want to talk to you a little bit about arthritis of the hip. Arthritis is the loss of the cartilage that coats the end of the bone. There's cartilage that coats the head of the femur. There's cartilage that lines the acetabulum or the socket. These cartilage cells allow the joint to move smoothly, provide a level of cushion per se. But when these cartilage cells die, that's arthritis. Cartilage dies for genetic reasons primarily, but it can be due to trauma. But also be caused by abnormal bone development in the hip socket and abnormal anatomic findings in individual patients that can contribute to the progression of arthritis earlier than just due to primary genetic factors. This is a picture of someone who has lost all the cartilage in the hip, and there is no space available between the acetabulum and the femoral head. Here is one where their cartilage is still preserved. So radiographically, we are looking for this type of hip before we think about treatment with a hip replacement. The way I perform hip replacement is I utilize a direct anterior approach, which is a less invasive approach to hip replacement. We make a small incision in the bikini line in the hip crease in the front of the hip. We then separate the skin and then get to two muscles that we separate. And once we separate those muscles, in retraction, we can see the hip capsule. We make an incision in the hip capsule, and then we can see the hip socket and femoral head itself. We utilize X-ray, and we also utilize robotics in these techniques as well. We make a cut in the femoral head and we remove the femoral head, and so the hip essentially looks very like this. So this has been removed, and through that small incision in that space, we're able to put a liner in the acetabulum or the socket. This is a titanium liner that has a plastic liner within it. It is wedged in position. We confirm its position. We confirm that it's in the optimal position with radiographs and with X-ray while we're in the operating room. We then, through that same incision, are able to place our hip stem, which fits and wedges inside the bone. We then place a ceramic head. We place it in position. We ensure that the leg links are symmetric to the contralateral side, and we do that with X-rays and are constantly monitoring the length during the surgery. With the hip reduced, we then close the capsule, let the muscles come back together, and then the patient generally walks out of the facility the same day. All of our hip replacements typically go home the same day. We utilize a spinal anesthetic. So typically people do not have a general anesthetic. It is a safe means of anesthetic and one that allows for easy recovery. Most patients with hip replacement we allow to put all of their weight on it immediately. And typically these patients are walking normal within 1.5 to 2 weeks, and by 3 weeks walk into the office with a normal gait without an assist device. That's either a cane or crutches. By 6 weeks, patients are doing most of what they want to do, certainly are playing golf, taking hikes, and by 8 weeks are doing everything they want to do. My patients ski, they hunt, they scout for elk in the mountains, they helicopter ski, they backcountry ski, Nordic ski, fly fish. There's very little that you cannot do with a hip replacement. It is one of the more successful operations we have. It allows people to get back to work, improve productivity, and generally have the highest patient satisfaction of all of our orthopedic procedures. When I perform a hip replacement, I utilize a direct anterior approach. This approach has two advantages. One, there's no damage of the muscle, there's no cutting of the muscle. We separate between a fascial plane between two muscle groups to access the hip joint and perform the procedure. The other advantage is that we are able to utilize X-ray throughout the procedure. It allows us to get the leg lengths perfect and the component positions perfect. In addition, we often will utilize robotics that allow us to perform the procedure in exactly the same way, but utilizing robotic techniques to ensure the position of the components and leg lengths as well. Either way, we utilize the direct anterior approach, which is a muscle-sparing, non-muscle cutting approach. The great thing about the way we do hip replacement is that many of our patients do not use narcotic medications. Not only are they putting all their weight on the hip and walking early and normally within a few weeks, they rarely require more extensive opioids. Often aspirin for preventing blood clots, an anti-inflammatory, or all the medications that are necessary in recovery from this procedure. After hip replacement, we do offer the opportunity to do physical therapy, but often patients do not need to do so and often do not utilize it.
Hi, I'm Sammy. I'm a nurse practitioner with Dr. Joshua Hickman at Mountain Orthopedics. Dr. Joshua Hickman specializes in minimally invasive knee replacement, hip replacement, as well as hip resurfacing. His total hip arthroplasties are done through a direct anterior approach. Dr. Hickman has been utilizing robotic-assisted joint replacement for the past 7 years. We have a dedicated team to each one of our patients. Our team includes a medical assistant, an administrative assistant, as well as 2 nurse practitioners. Our goal is to make sure that every patient is taken care of and has the best outcome they can, and that they get back to life they have been missing due to pain and activity limitations. Our team is accommodating and will go above and beyond for every single patient. We want to make sure that every preoperative and postoperative, as well as the recovery process, is seamless and easy for the patient. Today I'm going to talk about the recovery period for joint replacement. On the day of surgery of a hip or knee replacement, you will meet with Dr. Hickman shortly before surgery. All your last-minute questions and concerns will be addressed by him. We want every patient to be calm and confident before entering the operating room. During a knee replacement, the patient will receive an injection right above the knee. This is called a block and is done by the anesthesiologist. All patients will be rolled into the operating room. Dr. Hickman performs all his surgeries under spinal anesthesia. This does not mean you're awake. You will receive sleeping medication, rest comfortably during surgery, and wake up with less side effects. Spinal anesthesia has significantly less risk when compared to general anesthesia. A joint replacement generally takes 1 to 2 hours. After the surgery is over, you'll wake right up, go to recovery. As soon as your spinal wears off, you will get up and walk. You will put all your weight through your hip or knee. You'll go to the bathroom, eat a good lunch, and most likely go home the same day. Upon discharge, we want all our knee replacement patients walking as much as they can. There are no restrictions. We want you walking as much as you can, or at least every 2 hours. Knee replacement patients can go up and down stairs. They can get on a stationary bike or even a recumbent bike. The more stiff the knee is, the more it's going to hurt, so walking is key after a knee replacement. We also require walking with our hip replacements as well. We want our hip replacements patients walking every 2 hours. However, we recommend that the pain guide our hip replacement patients after surgery. If you are up and walking and your hip is sore and painful, then you stop, rest, and ice. Our knee replacement patients will start outpatient physical therapy 2 to 5 days after surgery. The patients will set this up on their own. You will call a physical therapist, one who lives near you so you are not traveling far. Tell them you're having a knee replacement and the day you would like to start physical therapy. Patients will attend physical therapy twice weekly, and the physical therapist will give you a home exercise program that you can do on your own when you're not in the physical therapy office. We do not require any formal physical therapy for hip replacements. Our only requirement is walking. We encourage all our hip replacement patients just walking every 2 hours, as mentioned. However, we give every hip replacement patient a formal physical therapy prescription, and it may be beneficial. We leave this up to the patient to choose if they want to do formal physical therapy. If not, they can just walk at home. After a knee replacement, the block or numbing medication wears off 24 to 48 hours after surgery. When this happens, you will know. There will be increased pain as well as swelling. Walking, ice, elevating, as well as medication will help with this. Bruising and swelling are very normal after a knee as well as a hip replacement. You may notice bruising and swelling all the way down to the toes. This is completely normal and will resolve over the next couple weeks. The first 2 to 3 weeks after any joint replacement is the toughest, as there is pain and swelling during this period. This is very normal and will improve. Night pain is also very typical. Patients often have a hard time falling asleep and staying asleep at night. Again, this is very normal and will resolve. After a joint replacement, you will go home with a brown bandage either on your knee or hip. You can shower the next day. You'll remove the brown bandage. Underneath the brown bandage is a clear piece of mesh. This mesh is glued onto your incision. The mesh makes it waterproof as well as keeps the incision closed. Do not peel the mesh off until your post-operative appointment. You can get in the shower, soap and water runs over the mesh. Do not scrub, pat dry, and you're all done. Knee replacements do not need to put a new dressing back on the incision. I do recommend putting a dressing back on the hip replacement just for the first 1 to 2 weeks. We rarely see any drainage or blood from the incisions. However, a few drops here and there are very normal. If you notice more than this, or if it's draining for greater than 3 to 5 days, please call our office at any time. Every patient is sent home with pain medication. We will discuss the most appropriate pain medication for you during your preoperative visit. In addition, every patient goes home with a blood thinner. This will either be aspirin or Eliquis, depending on you and your medical history. All medications are e-prescribed to your preferred pharmacy, as well as refills are e-prescribed to make the transition home much easier. We are available 24/7 after surgery. Please do not hesitate to call us with questions or concerns. You do not need to go to the ER or Instacare for any joint-related questions. If you call the office during business hours, we'll call you right back. If it's after hours, it will be redirected to our answering service, and one of us will call you right back.